السلام عليكم ورحمة الله وبركاته. مساكم بالخير جميعا. Good evening everyone and welcome to our summer school of diabetes. My name is Dr. Khalid Al-Dahmani. I'm chairman of academic affairs and consultant endocrinologist at Sheikh Tahnoon bin Mohammed Medical City and Tawam Hospital in Al Ain. I'm also the adjunct associate professor at Department of Internal Medicine and College of Medicine Health Science at UAE University in Al Ain. I'd like to thank Lily for supporting the Summer School of Diabetes, which comes to you after a collaboration between the Emirates Diabetes Endocrine Society and also the Emirates Family Medicine Society. For those who are joining us for this module, it is a 6 weeks course that covers the different aspects of diabetes with overall aim to give you a high quality, evidence-based practice material to help you with the diagnosis and management of diabetes mellitus. The course translates the EDS national guidelines into your day-to-day practice, and also the course is intended to standardize evidence-based diabetes care across primary and secondary care settings in the United Arab Emirates. It is targeted toward family physicians, GPs, internists, and fellows who are managing patients with type 2 diabetes and also patients with obesity. The course is CME accredited, and after you complete the course, you will receive certificate of completion. The course started 2 weeks back, and now we are on module 3. And module 3 will be covering weight from risk factor to treatment target. After this module, we have 3 more modules. 2 will be focusing on management of type 2 diabetes, and the last module will be focusing on complications of diabetes, recognition, prevention, and management. A reminder for those who are joining us for module 3 and who are not present at module 1 or module 2, you need to register and enroll in this course. You have to complete pre-learning MCQs for each module, complete the 6 weeks of learning of these modules, join us, interact with the speakers, ask your questions, and complete post-learning MCQs for each module, and then you will receive certificate for the Summer School of Diabetes. For those who joined us after the 2 modules, you can still go and listen to the first 2 modules through the EDS YouTube channel. The webinar will be available on demand on the platform and also on the EDS YouTube channel. For questions and answers, please submit them in the Q&A box. After each module, CME will be available and certificate will be provided after CME is received. The attendance is automatically tracked, so please stay with us, engage with the speakers, and if you have any technical issues, please share that with us in the chat box. The agenda for our module 3 this evening will include 4 eminent speakers, regional experts in type 2 diabetes management and in obesity management as well. Each speaker will be given about 25 minutes to present his title, and then at the end, we'll have Q&A with the presence of all 4 speakers. With that, I'd like to start with our first speaker, Dr. Fawzia Rashid. She's a consultant endocrinologist in the Dubai Hospital. She's also clinical associate professor at Mohammed bin Rashid University of Medicine and Health Sciences. She's associate editor in Dubai Journal of Diabetes and Endocrinology, and she will be presenting insulin resistance, the common soil. Dr. Fawzia, you can start your presentation.
Assalamu alaikum, everyone, and good evening. Thank you so much, Dr. Khalid, for your introduction. And I'm very thankful to the organizer as well as the Amrest Diabetic Endocrine Society for inviting me today for such an interesting talk today. So the topic of my talk today is insulin resistance, the common soil. I hope everybody can see my screen. This is, as Dr. Khalid mentioned, this is part of the third module, and from weight as a clinical imperative, from risk factor to the treatment target. So today we will cover certain learning objectives for our audience. The first, need to understand how the insulin resistance share the biological substrate, which links together obesity, prediabetes, type 2 diabetes, MASLT, and the vascular risk in these patients. We would like to recognize certain clinical phenotypes in which insulin resistance should drive therapeutic choices. And we will review also the routine clinical markers which are associated with insulin resistance. And we will also try to learn without over-relying on non-standard tests, how we can come across those patients into our clinical journey. And then use the insulin resistance framework to justify early weight-focused and cardiorenal metabolic focused intervention in those cases. So let's see the normal physiology of insulin. A brief recall that how this important hormone works. Up to the journey of endocrine system, I think the insulin is one of the essential hormone most investigated, talked about, and we all care about the level of insulins and that how it works in our patient, because the diabetes is now reached to the storm of the metabolic disorder in the world. So this insulin is an anabolic hormone with both metabolic and mitogenic effect. When a person takes its meal, insulin helps the body to store and use glucose by increasing glucose uptake in the muscles, liver, and adipose tissue. Insulin promotes glycogen synthesis by this high caloric diet or low caloric diet, so avoid the starvation. Insulin also inhibits the lipolysis, so we don't go into the stage of ketonemia, and it reduces gluconeogenesis in the liver. So this is all the usual physiological act of insulin in a person who has a normal physiological work without any resistance. So what is insulin resistance? When the same hormone which is secreted in a normal amount in a person does not give a normal biological response into the target tissue that are liver, skeletal muscle, and adipose. So when insulin works and stimulates, it doesn't yield the response which a body needs. And in turn, beta cell overproduce insulin, which leads to chronic hyperinsulinemia, which is the pathognomonic of insulin resistance. What is the epidemiology of insulin resistance? As per the National Health and Nutritional Examination Survey, as with the diabetes, insulin resistance is also on the rise. If you see in 2003 survey, 22% of the US adults are diagnosed with insulin resistance. This figure gone up to 40% by year 2021 in US adult population as diagnosed by the HOMA-IR. Insulin resistance is limited not to any race and ethnicity. Everybody can be having insulin resistance part of their living in this era, excluding the pediatric diagnostic criteria is not yet defined, so we do not know the prevalence of insulin resistance below 18 age of care. The rise is driven not only by the obesity, the insulin resistance is prevalent with hypertension, dyslipidemia, and physical inactivity. They are independent contributors to the development of insulin resistance. When we talk about etiology, we know the acquired insulin resistance causes majority of the cases because of the visceral adiposity, physical inactivity, aging population with poor nutritional habit, high caloric, high sodium diet, leads to glucose and lipotoxicity. Certain medication can also give rise to insulin resistance, predominantly the use of glucocorticoids, SSRIs, and antipsychotics that leads to insulin resistance and high yield of diabetes and dysglycemia in those patients who are taking this medication. Genetic causes include type A insulin resistance, where is the mutation in the insulin receptor, and that leads to severe insulin resistance, certain phenotypic abnormalities like acanthosis, ovarian virilization, and type B insulin resistance, which is autoimmune, and there is antibodies to the insulin receptors cannot work normally, and insulin levels high, that leads to hyperandrogenism and acanthosis nigricans as well. Certain syndromes are also associated with insulin resistance, like myotonic dystrophy, lipodystrophies, metabolic ovarian syndrome, Werner syndrome, Rapson-Mendelsohn syndrome as well. So in the vasculature, how the insulin works. It can be protective or it can be harmful, depending on which signaling pathway dominates. This is a very deep understanding at the level of the molecular signaling, and multiple molecular cascades are involved. Just to understand briefly, we have to see when a person takes food and in the postprandial state, insulin secretes from the pancreatic beta cell. It goes to the insulin receptor, and the usual pathway which activates via the receptors are P13K AKT3, which is a normal physiological pathway, should work in a receptor which helps the glucose uptake in adipose as well as the muscle tissue, leads to increased glycogen synthesis, decreased lipolysis, and decreased gluconeogenesis. That causes the metabolic control in a healthy individual without insulin resistance. The same pathway works in blood vessel via the endothelial nitric oxide synthase. With the production of nitric oxide, increased vasodilation happens in the endothelium, which is a healthy endothelium. While if you have a chronic hyperinsulinemia because of whatever underlying reason, whether this is a high caloric diet, physical inactivity, genetic causes, this leads to activation of the MAPK pathway. So we just need to remember the mitogen activated protein kinase pathway leads to generation of endothelin, which is a bad molecule, leads to the proliferation of vascular smooth muscle cells, chronic inflammation, and atherosclerosis. So at the level of the blood vessel, there is a chronic hyperinsulinemia related vasoconstriction, which is leading to the unhealthy endothelium throughout the body. And that's the pathway which is the pathogenic for atherosclerosis and low-grade inflammation. So when insulin is there in a normal physiological way, it shifts the body into the form of storage and repair mode. However, when the insulin signaling is resistant to its action, the protective metabolic pathway weakens and the pro-atherogenic vascular pathway become more prominent. So the direction of the MAPK pathway leads to more mitogenesis, promotes more inflammation, and leads to more atherogenesis. And what are the target tissue which are involved in the pathophysiology? There are three key sites, which are skeletal muscle, liver, and adipose tissue. So to understand, we know that skeletal muscle accounts up to 70% of the glucose disposal. Accumulation of the diacyl glycerol because of the excessive glucose activates the PKC theta pathway, which reduces the uptake via the decreased translocation of GLUT4 receptor, which leads to decreased glucose uptake. Chronic hyperinsulinemia and glucose load leads to excessive glucose trigger de novo synthesis in the liver, and more lipogenesis happens, which impaired suppression of glucogenesis, and ectopic fat deposition happen across the whole liver as well as the adipose tissue. This leads to more of the beta cell dysfunctions. So three major sites where insulin resistance creates issues are skeletal muscle, liver, and adipose tissue, and that contributes to worsening of the insulin resistance in these three sites. So we know that how the insulin is a core resistance problem in the core of all metabolic diseases. If you see here, the insulin resistance is not merely a consequence of the metabolic disease. Actually, it is a driver that bidirectionally reinforces each condition in the spectrum of those diseases. If we talk about obesity, the visceral adipose tissue, free fatty acid, and decreased adipokines, that leads to obesity. Type 2 diabetes results of the chronic hyperinsulinemia, glucotoxicity, and lipotoxicity. Polyendocrine metabolic ovarian syndrome because of the chronic hyperinsulinemia, and mast cell prediabetes, all of them have bidirectional relationship together. So this clinical phenotype secondary to insulin resistance affects our therapeutic choices. So as we are aware, and we see here that excessive carbohydrate intake over the period of time, particular genetic makeup, sedentary lifestyle, and excessive weight, all of them leads to insulin resistance. And this insulin resistance leads to multitude of the problem, including the hypertension, cardiomyopathy, atherogenic dyslipidemic pattern. And that's why we call insulin resistant as a central hub of all of these cardiometabolic diseases. So cardiometabolic epidemic, as per the most latest paper published just this month, it showed that this metabolic disease are frequently co-occurring. They're not independent. So one person who is diagnosed with obesity doesn't mean that they will remain obese forever. They may have overlapping multiple metabolic disorder as well. And that's because of the shared metabolic makeup of those patients. So across the globe, 32% of population have MASLD. 18% are suffering with obesity, and approximately 10.5% of global population have type 2 diabetes. So if we see here that out of those 32% of the MASLD patient, actually up to 22% of them have type 2 diabetes as well. And when we talk about obesity, up to 90% of obese patients have MASLD, which constitute a big population of our adult population. And up to 70% of type 2 diabetes have MASLD. So we see here the core of the problem is that not a single disease. Because of the metabolic interaction, this fusion happens and leads to multiple metabolic problems across the global population. And it is on rise because of our general insulin resistance, secondary to sedentary lifestyle, physical inactivity, and high caloric diet. And what is the thread linking them all together? It's insulin resistance, because all of these conditions are bidirectionally reinforcing each other. So if we talk about obesity, which is again a self-amplifying vicious cycle, obesity gives rise to insulin resistance because of the visceral adipose tissue hypertrophy, release of excessive free fatty acids, pro-inflammatory adipokines, that is TNF-alpha and IL-6, and that worsens the insulin resistance in return. Same problem goes with MASLD and obesity. This is again a self-amplifying vicious circle. Whenever the body have ectopic lipid deposition, it leads to worsening of the insulin receptors resistance because of accumulation of diacylglycerol. There is a lot of research going on across about the DAG accumulation and how to handle different peptides. But up till now, there is nothing which directly addresses and blocks these pathways. The particular phenotype which is of particular interest is lean muscle and sarcopenic obesity. What is the pathophysiology behind the sarcopenic obesity? It is loss of metabolically active muscle tissue, which reduces the glucose uptake into them. That worsens systemic insulin resistance. And lean muscle insulin resistance can drive hepatic steatosis without overt obesity because of the visceral adiposity, and insulin resistance are the critical determinant, not the BMI alone. So we see this particular phenotype in certain ethnicity. So that's why isolated BMI should not take into account. They have decreased skeletal muscle mass. They have more resistance at the level of the muscles and more visceral activated adipose tissue that worsens the insulin resistance, and they're metabolically prone to develop more atherosclerotic cardiovascular disease in this particular subset of the population. Prediabetes, which is against the very critical window before the dysglycemia even happen, there is insulin resistance. And different spectrum of the insulin resistance give rise to different form of dysglycemia. When there is a skeletal muscle insulin resistance, we see the postprandial hyperglycemia. When there is hepatic insulin resistance, this selective insulin resistance at the level of the liver give rise to fasting hyperglycemia. And if this condition persists over the period of time, this leads to progressive deterioration over the condition because of the compensatory beta cell hyperinsulinemia. For a period of while, it maintains normal blood glucose until beta cell exhaustion happen. And that drives this particular problem into the type 2 diabetes. And this self-perpetuating cycle continues, and the glucotoxicity leads to florid type 2 diabetes because of the dysfunction at the level of insulin resistance. So we see that certain clinical phenotypes are associated with insulin resistance, and we have to address this as per the particular drive. For example, the patient has atherogenic dyslipidemia, which is manifested as increased triglyceride, low HDL, high small dense LDL population. So we have to address this by particular lifestyle changes and the medication. If the patient have developed type 2 diabetes or pre-diabetes, we have to deal accordingly. Now, if we come to the routine clinical markers of the insulin resistance without over-relying on non-standard, this particular topic is very important to understand. Actually, we see in the clinical practice that a lot of patients have undergone certain kind of investigation and workup without any meaningful yield because of this. So first, we have to understand that insulin resistance is a pathophysiological state. It is not a disease. So there is no universal accepted diagnostic test for it. Clinical guidelines currently focus on detecting dysglycemia, that is prediabetes, diabetes, MASLD, or metabolic syndrome, but not insulin resistance per se. This particular distinction explains why many physiologically informative tests are not recommended for routine care. Here we see why. Because the gold standard test for measurement of insulin resistance is only hyperinsulinemic euglycemic clamp, which is a gold standard because it is done at the level of the research labs. It is invasive, it is time consuming, it is laborious. But how it is done? Because it's invasive, it's done under the constant insulin infusion. We see the variable glucose infusion to maintain the euglycemia between 90 to 80 milligram decimilliter, and we measure the glucose infusion rate. If higher glucose infusion, it means the higher insulin sensitivity, and it is reported as M value. What it measures the true whole body insulin sensitivity and direct skeletal muscle glucose uptake. It is a validation marker used at the level when you use certain surrogate clinical markers like HOMA, Matsuda, Koike, and used in the drug trials for the GLP, SGLT2, and thiazolidine groups. But what we use clinically are the difference. We use usually the clinical metabolic syndrome criteria. If you suspect a patient of insulin resistance, it's recommended to take into the individual whole history and the phenotypes into account to diagnose them insulin resistance. Like they have elevated waist circumference, they have waist to hip ratio, they have elevated triglyceride, they have low HDL cholesterol, higher BP or fasting blood glucose. If they meet this criteria, it means you are dealing with a person who have insulin resistance because they fulfill the criteria of the metabolic syndrome. The clinical surrogate measures which are used in certain clinical setups are HOMA-IR and HOMA-2, which measures the fasting glucose and insulin-based indices, Koike, which use quantitative insulin sensitivity check index, triglyceride over HDL ratio, and Matsuda and McCauley, which is again a computer-based post-load and fasting-based sensitivity indices. You use certain criteria and the calculation. The important thing to remember here, not to over-reliance on non-standard tests. What does it mean? You see frequently in the clinical practice, the oral glucose tolerance test has been used for certain patients. A lot of patients come that OGTT was performed and they were diagnosed as insulin resistant. So this practice is not recommended into the guideline because what OGTT actually measures, it's not measuring the insulin resistance. It is capturing your post-challenge hyperglycemia, which can be missed by single measurement of fasting glucose or HbA1c. It also reflects the beta cell reserve under stress, which is clinically actionable. It means that if you have a hyperglycemia after the glucose load, you have to address that by the pharmacotherapy. And what guideline endorse about the use of OGTT for the diagnosis of diabetes or pre-diabetes, for the diagnosis after the gestational diabetes or during the time of pregnancy, those patients who are high risk of developing diagnosis as a case of POMS or severe obesity, for them we can order them, and actually it is recommended to do OGTT for the diagnosis of their underlying dysglycemia. And ADA also recommend to use OGTT in case you have discordant A1C or glucose values, certain hemoglobinopathies or uremia, etc. But to diagnose solely for the insulin resistance, no guidelines yet endorse that. When the clinical question is dysglycemia, go ahead for that. But to tell a patient that you have insulin resistance by doing OGTT is not recommended. Another test which is frequently used is insulin level. So what guidelines tell about that insulin testing only shows us that there is compensatory hyperinsulinemia. It has some value when there is early insulin resistance before even the hyperglycemia develops. It can identify that. But otherwise, it can only be used for mechanistic and academical setup when you have certain parameters. And again, with the infusion of glucose, we use it. Guideline position the level of insulin not as a marker because it is having no standardized assays. There is no validated cutoff to label a patient having a hyperinsulinemia or insulin resistance. It has poor interlaboratory reproducibility. Different labs have different level of insulins to cause them high insulin level. And most important of all, it does not change approved treatment pathway. If a person who is having high insulin in the background of metabolic syndrome, dysglycemia, dyslipidemia, hypertension, high waist circumference, you are going to offer them treatment pertaining to their metabolic phenotype. High insulin level, you're not targeting as per the treatment. But there are exceptions to measure for insulin levels there when you have a severe phenotype of insulin resistance, mostly in the background of the genetic causes or lipodystrophy. So if you have a patient who may be having a lean phenotype but having a sarcopenia, you find them, they may have visceral adiposity, and you suspect them to have type A or type B insulin resistance, you can check for insulin level for them at the level of 8 hours fasting. If they have a marked hyperinsulinemia in the background of normal or high blood glucose, this exception can be done for insulin level check. So why guideline avoid insulin resistance testing in routine clinical care? So in a routine clinical setup, there is no distinct treatment target for insulin resistance itself. We have to identify insulin resistance in the background only when the patient having weight and BMI higher than for their height, they have dysglycemia. You are evaluating for cardiovascular risk, hepatic steatosis, and POMS. So you are measuring patient clinical risk, not by the biochemical insulin levels. So in general, when we interpret routine clinical marker of insulin resistance, We are measuring their lipids in view of increased triglyceride, low HDL. So we are targeting atherogenic insulin resistance pattern. We are measuring their waist circumference. We are talking about the visceral level of adiposities. When we are measuring glucose by the OGTT or fasting or HbA1c, we are checking their dysglycemia markers. When we do ultrasounds for the checking of their hepatic steatosis percentage, we're talking about MESL, which is a marker of hepatic insulin resistance. Checking of the office blood pressure or dyslipidemia, which is the vascular insulin resistance marker. So all of these surrogate markers are actually required, which is supported by the evidence and the guideline, and you do not need any particular biochemical test to diagnose a patient. So when we talk about, in summary, the key tests for insulin resistance, the gold standard is hyperinsulinemic euglycemic test, routine clinical test, fasting glucose, fasting insulin, A1C, OGTT, C-peptide in certain subset of the patient where you have a doubt about their usual diagnosis and you are suspecting some kind of genotype which leads to the insulin resistance. Calculated indices usually done in the set of the research and certain drug effects. Metabolic assessment like lipid profile, liver enzyme, renal function, part of the routine clinical testing. Anthropometry should be part of the metabolic syndrome and routine clinical testing. Hepatic assessment, again, the part of the routine clinical testing when you suspect a patient who may have fatty liver. Inflammation, adipokines, and advanced research is also part of the research setups. So when we use insulin resistance framework to justify early weight focus and cardiorenal metabolic focus intervention. So what is the treatment for that? So the most important thing to understand that any patient you suspect to have insulin resistance, the treatment involves the dimension about caloric restriction, physical activity, low glycemic index carbohydrate diet, education of the patient in view of their educational background, social support, and design a personalized program for the patient, because certain patient may have physical limitation because of obesity. They cannot do physical activity, walk and exercise. So we have to design a personalized program to help them in their enhanced physical activity. So intensive lifestyle intervention is the treatment of insulin resistance per se. Because insulin resistance is the core of metabolic syndrome, lifestyle intervention remains the cornerstone of therapy for insulin resistance. So we have to remember this. And why the lifestyle comes first. So when we talk about weight-focused treatment, we have enough data. And why this enough data? Because treating insulin resistance early prevents the metabolic memory that leads to irreversible vascular and organ damage. Intervention must be weight-focused and CRM-focused. Weight loss, specifically reduction of the visceral and ectopic fat, directly reverses the lipotoxic inhibition of insulin signaling via the DAG and PKC pathway we saw earlier. A weight loss of 7 to 10% is required to resolve the MASH and significantly improve fibrosis. Even modest loss of up to 5% can reduce hepatic steatosis, and 7 to 10% dramatic reduce the insulin resistance and helps to sensitize the body for the action of the insulin. Diabetes prevention program is one of the iconic trial which was done in earlier decade of 1997. This program was randomized controlled trial of the 3 arms subject to the placebo group, intensive lifestyle, and metformin, designed to see the progression and development of the diabetes in these 3 arms of the patient. The intervention arm was subjected to lifestyle changes, aiming for up to 7% of the weight loss and 150 minutes of the physical activity. Metformin group was given metformin and placebo was given no intervention, no, and the usual care only. And this group was followed for the development of the type 2 diabetes. The results show that up to 7% of weight loss in the intensive lifestyle group reduced the onset of diabetes by 58%, which is the most powerful lifestyle outcome in the clinical evidence and so far in the history. While the group which received only metformin with usual care, they have reduction of type 2 diabetes onset by 31%, effective but inferior to intensive lifestyle changes. So DPP trial has been forwarded further to see the development of the microvascular complication. So what we observe in this trial that actually the development of diabetes halted and it's not leading to the avoidance of the complication. However, the people who have not developed the type 2 diabetes, they have far less incidence of the microvascular complication. So if you see here the group in the green, which is the lifestyle intervention, they have far less prevalence of the neuropathy compared to the group of metformin and the placebo. Same goes for the nephropathy. And in aggregate altogether, the development of microvascular complication was far less compared to the other group in the lifestyle intervention. However, this protection is lost in those patients who have developed diabetes and they keep on having the microvascular complication in future onward. So development of diabetes yield shows us that prevention is better because once it develops, it is the key driver of all the microvascular complication to happen. So our focus should be to prevent the onset of type 2 diabetes, because once the type 2 diabetes develops, the complication is bound to happen here. In view of this diabetic prevention program, there is a outcome study was carried on, which is known as Diabetic Prevention Trial Outcome Study. This study is actually still happening, but the data published in 2025, which showed the 3 arms were followed over the period of follow-up. And up to 2021, if you see here, the same group of people who receive intensive lifestyle intervention versus metformin and placebo, the development of diabetes, which was reduced by 58% in lifestyle group and 31% metformin group, has continued over the period of next 13 years, and the diabetes keep on reducing by 24% in the patient who were subjected to intensive lifestyle intervention, while in metformin it reduced to 17%. The DPPO program was adopted by the Diabetes Prevention Group, is research group by the National Institute of Diabetes and Kidney Foundation of the USA, and they keep on following for the timeline development of that complications in 3 groups over the period of the time period. And what
1 minute, Dr. Fawzia. 1 minute.
Okay, Dr. Khalid, we'll be fast. So we see here that lifestyle intervention over the period of time has led to weight loss, and weight loss significantly affected the prevention of diabetes and all the complications. The Look Ahead research group also reinforced that weight loss has caused intervention group more meaningful change in the prevention of the type 2 diabetes, but it failed us to show that cardiovascular disease do happen in those groups who have developed the type 2 diabetes. This particular adaptation and it strengthens the value that weight loss treatment definitely affect the patient from prevention, but it will not affect the patient from development of the cardiovascular risk reduction. This particular concept has led us from isolated organ-based management to the CKM-based management, that we should focus before prevention, and after prevention has failed and type 2 diabetes has developed, we focus more onto the CRM-based management. And this glucocentric model failed to explain early vascular risk, development of muscle and obesity. And here the CKM stage has been adopted by AHA. And what we focus here actually in the reverse direction. Risk need to be understood here at a stage 1 and a stage 0, because once the stage 2 has developed, the pharmacotherapy intervention has become mandated based on the individual risk factor of the patient. There is no specific medication approved for insulin resistance. So we have to focus on the visceral-based, patient phenotype-based pharmacotherapy. And there are many medications over the period of time have shown great benefit in terms of the CRM benefit. GLP-1, GLP combined with GIP-1 signaling has shown across the data. If you see, there are at least 15 and 20 trials have shown based on the HOMA-IR, reduction of insulin resistance, decreased inflammation, decreased lipotoxicity, and in general, reduction of the cardiorenal metabolic risk, irrespective of weight reduction, irrespective of the glycemic benefit. So we can safely have seen this in Synergy MASH trial, in Surpass trial, that reduction of the weight as well as the reduction of the inflammation, glucotoxicity, improves the insulin sensitivity across this general population. Same data has shown in SGLT2 group that it reduced the insulin resistance through the reduction in the hepatic fat, reduced glucotoxicity, promotes weight loss, and enhances the adipose tissue remodeling. So all of these pharmacological intervention works at different level to help the patient with different phenotypes to achieve the goal of weight loss and cardiorenal metabolic benefits. So the key takeaway today is that insulin resistance is a central pathophysiological mechanism underlying numerous cardiometabolic disorder. a major precursor to cardiovascular disease, and early intervention through lifestyle modification is cornerstone. Insulin resistance is best managed by treating the phenotype early rather than when the over disease has developed. Therapy to reduce insulin resistance by GLP and combined GLP-GIP agonist, SGLT2, with particular focus to CRM staging is critical for improving metabolic health and reducing long-term cardiovascular cardiorenal complications. I will end my presentation today with the message that intensive lifestyle intervention should be prescribed and not just advised, designed to your patient with particular need. Thank you so much for your attention.
Thank you very much, Dr. Fawzia, for informative talk. Now we move to our next speaker, Dr. Lameen Abdelkader. He's a consultant endocrinologist at Dubai Hospital. He's Associate Professor of Endocrinology at Mohammed bin Rashid University of Medicine and Health Sciences. He's a Fellow of the Royal College of Physicians, UK, the American College of Physicians, and the American College of Endocrinology. And he will be presenting to us obesity, muscle. Give me the title again. 3 diseases in one. So obesity, muscle, and diabetes, 3 diseases, 1 axis. All yours, Dr. Lameen.
Thank you very much, Mr. Chairman, for the kind introduction, and thanks to the organizers for having me today. It's lovely to be here again in the Diabetes Summer School, and the EDS and EFMS are making our summer busier than what it used to be. And thanks for the colleagues who are being here around for mutual discussion and clinical knowledge sharing. So as Mr. Chairman mentioned, that I'll be tackling the obesity, muscle, diabetes, the 3 diseases in 1 axis. And this is my disclosures. And by the end of this talk, I'd like all of us to agree on 2 overlaps. The first overlap is between my talk and Dr. Fawzia's talk, and this is probably for the good turnover of the informations and probably comparing many transformation from the basic science to clinical evidence and epidemiological data. And the second overlap is that the overlap between obesity, muscle D, and diabetes. And just paving the road, let's see what's the trend of having these triple diseases globally and regionally. And as you all know, that the prevalence of obesity is on the rise over the last 4 or 5 decades across the globe. And probably females are more affected than males in terms of prevalence of obesity. And the GCC country, part of the MENA region, is an exception because the mean obesity prevalence in the global indices is between 16 and 20%, while in GCC, this era, it's between 25 to 45% of total population are living with obesity. And that, as you can see, the trend is still going upwards unless further actions have been taken. Similarly, we can see the same trend in diabetes prevalence across the globe, again, over the last 3 to 4 decades, going hand in hand with the obesity prevalence. Nonetheless, the lost treasure or the lost chamber is the muscle D, where we can see even more abrupt uprise in prevalence across the globe, more importantly in people living with type 2 diabetes, as well as people living with obesity. And probably the explanation for that, more than the higher prevalence, is the underdiagnosis of muscle D, where at this point in time, probably they were called NAFLD, or just fatty liver, or NASH. And now there is more understanding and more tools to discover and detect muscle D and MASH. So again, the GCC area, part of the MENA region, is an exception where we can see the highest prevalence of muscle D across the globe is in some of the GCC countries, where Qatar and Kuwait are the highest in the world, ranging between 44 to 45% of the total population are living with muscle D. Okay, so the prevalence is going hand in hand, obesity, muscle D, and diabetes. This is even more further understood or elaborated, where majority of patients living with diabetes are living with muscle D as well. So around 65% of people living with diabetes are having muscle D. Around 30% of them are having more advanced form of muscle D, which is MASH, where there is more of sort of inflammation to the hepatocytes. And around 15% of all people living with diabetes are having an advanced fibrosis. And this is the area where, almost an area where there is no return to normality, but we can do some job to downsize the effect of the advanced fibrosis. So 15% of people living with diabetes are probably having an advanced fibrosis. Similarly, the general population in the world are living with, are having 30% of the general population are having muscle D, while in the MENA region, the mean prevalence is around 39%, while people with diabetes and muscle D are ranging between 65 to 69% from the global prevalence into the MENA region prevalence. So in obesity, diabetes, and muscle D, the region where we are practicing in is having the highest rates. We tried in one of our the patients' cohorts, where over 90,000 individuals with risk of muscle D, to do the logistic regression to link what's more associated with muscle D. Is it overweight, diabetes, obesity, kidney function, total cholesterol, or HDL or LDL? And as you can see, the most determinant of the risk of muscle D is overweight, diabetes, and obesity. Risk increases by 1, 2, or 3 folds compared to people with none of those underlying conditions. So those 3 conditions, they usually come in combo and they don't come in silos. And this is the reason why now the part of the definition of muscle D, you need to have one of the cardiovascular risk factors, which is dyslipidemia is one of them, obesity, type 2 diabetes. And in earlier stages of muscle D, there is higher prevalence of all, but in MASH, almost between half of the patients, up to 83% of the patients are having one of those associated comorbidities. And again, so it's a triple combination in addition to other cardiovascular risk factors. They don't usually come in silos. Very important point to take care of, that the higher prevalence of muscle D over the years is due to obesity is a very genuine logic. However, it does not decode the whole puzzle. In the same population that we have just addressed, there is around 21% of the total population are having moderate to advanced risk of fibrosis due to muscle D. However, 15% of those population were not obese, were not living with obesity, and neither having overweight. So they were what's called the lean muscle D. And this is almost always missed, because usually the entrance or the entry point of the detection of muscle D is usually obesity and some sort of metabolic syndrome. So we shouldn't ignore this category of patients, and this probably will discuss it in future talks. So there is a triple overlap between 3. Dr. Fawzi have mentioned many of the key understanding points, and I'll just take you again to the same point that she has probably alluded to, that the insulin during the normal physiology is a very decent and useful hormone. But when it gets mad in terms of insulin resistance or insulin deficiency, then the things go the wrong way. So during the fasting state, it has completely different function from the fed state, which is a postprandial phase. During the fasting state, it's basically a source of the production of energy through the destruction of the glycogen or glycogenolysis or formation of the glucose through the gluconeogenesis from the amino acids and the lactic acid. This increases the liver glucose output for energy sources. And in the adipose tissues, it increases the lipids destruction or fat destruction, giving more fatty acids free to generate also energy. So during the fasting state, insulin works as the energy generator. While during the fed state, which is a postprandial phase, it basically preserves energy and utilizes what has been already generated from the meal that has been just taken. So it increases the glycogen production, it increases the fat or lipid production, both centrally and peripherally. And Dr. Fawzi have just mentioned that in case of hyperinsulinemia, there is excess fat deposition, whether in the liver, pancreas, or peripherally, whether the subcutaneous or visceral fat or adipose tissues. So it increases also the glucose uptake by the muscles, where this is the main source of energy utilization across the human body. Insulin resistance have been covered by Dr. Fathiya, Dr. Fawziya quite well. And just to take you to link the three triple syndromes or triple diseases, I'll take you a little bit backwards also to the healthy adipose tissues, where they look very shiny and well demarcated. They look really beautiful. But when there is a genetic predisposition of those fat cells to become abnormal, or when there is an early obesity or overfeeding syndrome, then those fat cells or the adipose tissues will deform with time. They will hypertrophy, leading to more hypoxia and concomitant the nuclear and cellular distress or stress, increasing the inflammatory markers, destruction of those fat cells, leading to necrosis and lipolysis, and spillover of what's inside those hepatocytes. And this, as Dr. Fawzi have mentioned, that will reduce the good adipokines, where those are the hormones or the molecules who work as anti-inflammatory, insulin sensitizers, and anti-atherogenic factors. It will also increase due to destruction and spillover of fats, the increased free fatty acids in the circulation, which is an important cardiovascular risk. And it will reduce the adipokines. It will increase the adipokines, which is the bad adipokines, which will promote insulin resistance, dysglycemia, and systemic inflammation. This will in turn stimulate the immune cells to further lead to inflammation into these fat cells and both in central and peripheral locations. Those all together will lead to a couple of syndromes, including the destruction of beta cells, leading to beta cell apoptosis, insulin secretion reduction, and potentially type 2 diabetes, as well as the fatty liver disease or the MASLD due to excessive fat deposition and quite higher hepatic glucose production. And this is also a concomitant condition that increases the risk of diabetes and cardiovascular disease. Okay, so we probably by now we agreed that there is one axis, there is a combo of those metabolic conditions that promotes having them together at one time. So there is one axis leading to this combination of conditions. Then logically, this could have one strategy that works in the three of them at once. So Dr. Fawzi have mentioned earlier that weight loss might have a favorable effect on MASH or MASLD. So, and this is a meta-analysis of different dietary intervention protocols that led to substantial weight reduction. And when there is more than 15% weight reduction of the total body weight, there is remarkable regression in the MASH condition or MASH resolution. And this is also seen by the surgical intervention, and where we see much higher the weight reduction. However, they also subcategorize those patients here, and they followed them for 5 years. So if the weight reduction was initially between 0 to 5 kilograms per meter square, which is a BMI score, or the BMI score 5 to 10, or more than 10 BMI points. The higher the BMI loss, the higher the resolution of NASH at that time. This is an old data. Now it's called MASH. 90% of MASH cases have resolved after 5 years of follow-up post different surgical intervention with a sleeve gastrectomy or Roux-en-Y bariatric surgery. However, even if the BMI is just between 0 to 5 points, there is still 60% reduction in NASH prevalence compared to probable either static or progressed NASH in around 40% of those patients. And here they just sub-dissected the patients according to the fibrosis stage. The white one is the F0, where there is no fibrosis. And then the darker the shade is, the higher the fibrosis category. And as you can see here, the baseline, there is only handful of patients were living with normal liver histology. And after 1 year, almost a quarter of the patients were having completely normal hepatocytes or liver architecture. And after 5 years, 60% of patients who underwent surgical intervention in bariatric surgery, they had resolution of NASH. 60% regression of MASH resolution or MASH prevalence, compared to just around 10% in the patient's pre-surgical status. So weight loss, whether it's the nutritional intervention or surgical intervention, does lead to MASH resolution. And we all know that weight reduction due to intervention of nutrition and surgery does lead also to regression of diabetes and complete reversal and remission of diabetes. So again, the one axis works in the pathogenesis, in the prevalence trend, as well as in the outcome of any intervention to reduce weight. This also works in the pharmacological intervention, and we've seen that in the medications, which those whom have already been designed to be anti-hyperglycemic medications, but in the end, we've discovered that they work very well in obesity management, and then muscle D, and then cardiovascular and renal outcomes. So this is the semaglutide, the ESSENCE trial, where it showed a remarkable resolution of MASH. In almost 65% of the total population had regression of MASH status compared to around 35%. So double the rate of the placebo arm, improvement of more than one stage of fibrosis backwards, of course, again, double the placebo arm. Combination of both, again, double the placebo arm. And this is a medication which has already been designed to be anti-diabetic medication and proven to be a very strong anti-obesity medication as well. So the one axis works in the non-surgical, non-pharmacological intervention line. It works in the surgical intervention line. It works in the pharmacological line as well, both in semaglutide and tirzepatide here. And again, the higher the dose, the more remarkable the resolution of MASH, even earlier at 52 weeks compared to 72 weeks in semaglutide. So the anti-diabetic medications do work well, including the pioglitazone, which is historically known to have some effect on the fatty liver and MASLD. And as you can see here, almost 4-fold higher the resolution in NASH. This is again an old data. 3-fold higher the improvement in even patients who did not complete the whole study. Just a few weeks of exposure to pioglitazone did work in that. and those who completed the full data set, that there is almost 4-fold improvement in NASH or MASH compared to placebo arm using pioglitazone. All anti-hyperglycemic medications, many of them are anti-obesity medications as well. They do work in the MASH and MASLD. And this concurs the full continuum of the triple syndrome, from the pathophysiology, prevalence trend, clinical symptomatology, and having all of them at the same time, even part of the definition, as well as any intervention to treat them. And this led the American Diabetes Association to combine the three of them in one box. So when we are considering treatment, consider the three of those triple combination at once: the obesity, diabetes, and MASH. The background or the load bearing of the management protocol is a lifestyle intervention, and this is of paramount importance. And I fully concur and agree with Dr. Fawzia that this has to be prescribed, and this is probably all of us are really lagging behind in giving a structured and well-designed advice into lifestyle modification. So in short, I'm sure many of you have seen this, that whenever you are treating a person living with obesity or type 2 diabetes, consider the MASLD as well and look at them at the same time. We don't have any data that needs to intervene in MASH F0 or F1. This is very early stage. So probably treating obesity and type 2 diabetes will work in improving this state, bringing it back to F0. If it's F2 and F3, and this is where we have plenty of evidence. And again, as you can see, GLP-1 receptor agonist, for example, works in obesity, in diabetes, in MASH. We don't have enough evidence yet in the compensated cirrhosis, which is the advanced fibrosis stage. So we need to avoid any pharmacological intervention here. But for treatment of diabetes, we can use, again, the GLP-1, GLP-GIP, or pioglitazone for diabetes, GLP-1, GIP for obesity management with caution, because the patient is already trending or advancing into advanced fibrosis. When it reaches the decompensated liver, then all pharmacological interventions are better to be avoided, and the insulin is usually the safest to treat type 2 diabetes. So with that, Mr. Chairman, dear colleagues and friends, please allow me to conclude that obesity, MASLD, and type 2 diabetes are epidemiologically inseparable. Roughly 2 in 3 patients with type 2 diabetes already carry the MASLD status. Adipose tissue expandability, failure, and ectopic lipid deposition are the shared upstream lesion driving insulin resistance in liver, muscles, and beta cell alike. Incretin-based therapies and metabolic surgery are the first interventions to modify obesity, MASLD, and dysglycemia simultaneously and treat the axis at once, not the label, which is every syndrome by itself. And with that, I'd like to thank you very much and happy to answer any questions in the end. Okay, so Mr. Chairman is away for 5 or 10 minutes, and I'll jump into his position, and it gives me great pleasure to introduce my dear friend and colleague, Dr. Rahila Bati. She is an expert in obesity before being consultant endocrinologist, and she is one of the affiliated national clinical fellows for the European Society of Study of Obesity. And currently, she is having also a specialist profession in aviation medicine. She's multitasker. She's expert in the field of the metabolic syndrome and obesity. So no one is better than her to tell us about the clinically meaningful weight loss. Dr. Rahila, the floor is yours.
Thank you so much for a kind and introduction, Al-Amin. So it's difficult to follow, Al-Amin, I must say. My task today was given to talk about clinically meaningful weight loss. in terms of obesity and type 2 diabetes. So these are the learning objectives. First, let's see what is clinically meaningful weight loss. And then looking at, are there something else that we can look into apart from your body weight, which we normally measure, to help us in evaluation, assessment, and managing our patients better. And then talk a little bit about anti-obesity therapy and how we can communicate this in a non-stigmatizing way to improve the adherence of our patients. So in 2007, FDA actually first defined that any weight loss which is more than 5% is a reasonable marker when we are looking at efficacy of these novel anti-obesity medications. And that is the reason that weight loss of more than 5% is accepted criteria as clinically meaningful weight loss. And it is the current recommendation in all the guidelines for weight loss target for individuals who are living with obesity and its complications. However, we know that, and as Dr. Al-Amin has shown us, that in some patients we require more weight loss to get remission from some of these complications. And then we also need to keep in our mind that ethnicity, age, how the adipose tissue is distributed, and the duration and the severity of the disease all should be taken into consideration when we discuss important health benefits. And 5% weight loss is no to have HbA1c of less than 7%, or if you're using a CGMS, you want a target in range of more than 70%. And now we have moved more towards cardiometabolic first approach, like my colleagues have shown today, that for the cardio-renal protection, we should consider first SGLT2 inhibitors or GLP-1s. If you look at the hypertension guidelines, and these are from 2025 American Association for Cardiology, for adults with high blood pressure and known cardiovascular disease, we have changed the targets now as more and more data is coming in. And we now say pressure target of less than 130/80 is recommended. So what is common in these guidelines? Both guidelines target other risk factors. It's not only about targeting the HbA1c, it's not just targeting about a particular target for the blood pressure. We are looking at a bigger picture, and we are talking about time in range. We're talking about cardiorenal protection with both these diseases.
Dr. Rahel, can you share your slides?
Sorry?
We can see your slides.
Okay. Thank you so much, Dr. Khaled. Can you see them now?
Not yet.
Not even now. Okay, I'm just going to share again. Can you see my slides now?
Yes.
Okay, thank you so much, Dr. Khaled. Thank you. So I'll carry on from here. That, like I said, for diabetes and blood pressure, we have got guidelines which target all these risk factors. If you look at cardiovascular disease in itself, we talk about primary prevention, we talk about secondary prevention. Even within primary prevention, if you look at this update of the 2025 hypertension guidelines, We've started talking about use the PREVENT calculator if it's less than 10% of risk of atherosclerotic cardiovascular disease. Now we have got different targets for your LDL, different targets for your non-HDL cholesterol. So if you have got risk of more than 10% and you want to prevent the cardiovascular disease, you will aim for LDL of less than 70. But if it is less than 10% on the calculator, you're going to aim for less than 100. Let's look at diabetes. If you have diabetes without any risk factor for the cardiovascular disease, you're aiming for LDL of less than 100. But if you have got cardiovascular disease risk factor, you are now aiming for less than 70. You start looking at the apoprotein B goal of less than 70. So if you look now, the guidelines, they are looking at different targets for primary or secondary prevention. So what about obesity? Why we are still stuck on just weight on the scale for patients who are living with obesity? So this is an excellent work done by Professor Luca Bussetto, and he presented it this year at ECHO. And what they looked at was they took the data from the UK clinical practice research, which is from including all the primary practices, primary care practices, and it's a population-based cohort study. And they included patients between the age of 18 and 60 years. And the aim of the treatment was to look at how can we decrease the risk of particular obesity-related comorbidities in an individual where we are saying that they're moderate to high risk to a low 10-year risk of developing any obesity-related complication. So they looked at the associations between BMI, the waist-height ratio, and changes in the anthropometrics after the weight loss were calculated. In this study, they have focused only on 4 obesity-related complications, including type 2 diabetes, hypertension, osteoarthritis, and atherosclerotic cardiovascular disease. And what they looked at was, if you looked at what is the stronger association, so it's quite interesting that the waist-height ratio and BMI was a strong predictor for type 2 diabetes and blood pressure. But on the other hand, BMI was a better predictor for hip or knee osteoarthritis. And if you look at atherosclerotic cardiovascular disease, waist-height ratio was a better predictor for patients with obesity that can develop type 2 diabetes. Then the next part of this study was, or the next secondary outcome for this study was, they followed these patients over a period of 6.5 years. And then they looked at a low reference risk calculation. So they looked at the change with the 10-year risk of developing these 4 ORCs and calculated the risk, which was age and sex specific. So let's look at the results. Now let me talk you through this. So these are receiver operating characteristic curves, the ROCs. And what they showed was that they looked at the absolute risk and the weight change in the cohort. And if you look and focus on type 2 diabetes, what it showed was that at 3 years, BMI and the waist-height ratio again was more prominent predictor. Same is true for hypertension. But when they looked at the atherosclerotic cardiovascular disease, it's not the percentage of weight loss at 3 years. It was actually the percentage of change in the waist circumference, which was more important predictor. And the other important finding from this study was that the percentage change in the weight that we normally look at, and I've already shown it to you, it wasn't a great predictor for these obesity-related complications. It was the waist-height ratio and the BMI. So other chronic diseases such as type 2 diabetes, blood pressure, they don't rely on percentage improvement. They have the treatment targets, as these targets are associated with reduction in the risk of mortality or morbidity. Absolute waist height ratio and BMI levels after the weight loss at 3 years were more accurate indicators of lowering the 10-year risk of obesity-related complications rather than percentage change in the weight or the waist circumference. And that brings us to this recent paper, which was just published last month. And they've tried putting it all together and given us the concept of remission in obesity, just like I explained the remission in diabetes. So, based on the previous work which was published in 25, this review article, it talks about what adiposity target I should look for in my patients living with overweight or obesity. So 2 things stand out. One is BMI of less than 27 and waist height ratio of less than 0.53. And the objective improvement or resolution, usually using the complication-specific clinical endpoints. For example, blood pressure. So what is the blood pressure target? Obstructive sleep apnea, whether the patient is using the CPAP or your AHI scores. For MASLD, what is the FIB-4 score or the improvement in the FibroScan. And don't forget about the improvement in the physical capacity or the functional improvement and quality of life in these patients. Psychological well-being. The patient might say, yes, I feel so much better in myself now. And that is part or should be part of remission. And can it be 1 month, 3 months? No. They think that it should be sustained for more than 6 months for it to be more meaningful. And lifestyle, pharmacological agents, or surgical pathways, they all lead to this remission. And if we combine it all together, it can reduce the burden of obesity or overweight on our systems. Apart from the percentage of weight loss, BMI, waist height ratio, what else can we look at? So I like this staging, which was work of Dr. Arya Sharma on EOS, the obesity Edmonton obesity staging system. So stage your patient at start of the treatment and then stage them as a follow-up, and then you can actually show that there is reversal or there is remission of the patient in the obesity related complications. This is just to summarize all the pharmacological therapies that are available to us at the moment for weight loss. The important thing to note is that with the incretin, as the incretin-based therapies have started coming in, you are starting to see more percentage of reduction in the body weight, ranging from 10% to 22%, depending on the agent that you're using. And I've tried to summarize all the trial data on semaglutide in this. And it is to look at, just like I explained to you, the 5%, 10%, and 15% weight loss. If you look here, the STEP 2 trial was looking at the semaglutide in patients with type 2 diabetes. And if we look at clinically meaningful weight loss, which is more than 5%, almost 70% of the patients, they achieved that. And 26% of the patients with type 2 diabetes actually managed to achieve more than 15% of weight loss. What about combination of GLP-1 and GIP, which is your tirzepatide? Again, if you look at the SURMOUNT-2 trial, because it included patients with obesity who had type 2 diabetes as well, 82% of the patients, they actually achieve more than 5% of the weight loss in this study. So when we talk about different targets, let's look at different clinical trials and see how these targets of BMI of less than 27 or the waist height ratio of less than 0.53 has been validated in clinical trials. So SURMOUNT-5 is a clinical trial which was head-to-head between semaglutide 2.4 milligrams and tirzepatide. And this is an analysis which is not based on the weight loss, We are now looking at these two markers, which is BMI of less than 27 and waist height ratio of less than 0.53. So if you look at these patients, 20% of the patients, they achieved BMI of less than 27 with semaglutide, and almost 34% they achieved that BMI target with tirzepatide. But if we combine these two markers, you can see 15% of the patients achieved both targets with semaglutide, whereas 23% of the patients achieved it with tirzepatide, which is 1 in 4. And that is where the concept of this target to treat is coming up. Now, my colleagues have all spoken about cardiometabolic parameters. So let's talk about these cardiometabolic parameters. And this is the work which is done by Luca and Calderu. And what they did was, so they looked at all the participants who have achieved semaglutide as well as tirzepatide, looking at normoglycemia, the triglyceride component, improvement in the HDL, improvement in the blood pressure, and the high sensitivity CRP was targeted at less than 2. And if you look at the second table, here what they have done is, now you have combined it at how many of these patients actually managed to achieve more than 3 goals, more than 4 of these cardiometabolic goals, or all goals. So if you look at all goals, which is all 5 of them, again, 24% of the patients achieved all 5 cardiometabolic parameters with tirzepatide, and 16% of the patients, they achieved it with semaglutide. And now if you look at treat to target, why are these different? So now you have excluded the patients who actually achieved waist height ratio of less than 0.53. And then in the bottom of the graph, you have combined the two parameters, which is BMI of less than 27 and waist height ratio of less than 0.53. And then apply all these 5 cardiometabolic parameters to see how much of those goals are achieved. And now the numbers, they are totally different. So if you look at the bottom, patients who achieved in SURMOUNT-5, these two targets, they are now divided into these goals. And 100% of these patients who achieved these two targets, they achieved at least 3 or 4 those cardiometabolic goals with both the medications. And if you look at all the 5 goals, with semaglutide, 44% of the patients, they achieved it with semaglutide, and 37% of the patients, they achieved all 5 cardiometabolic parameters with tirzepatide. Then this is a prospective study called SEMALEAN study, which was just published last year. And this was done on semaglutide, 2.4 milligrams. What they looked at was, they looked at the body composition, which was done by the DEXA scan. And the purpose was looking at the changes in the anthropometrics. So yes, these patients lost the same amount of weight that we see in our clinical practice as well as in the trial data. But the important thing to learn here is there was reduction in the fat mass at 7 months and 12 months. And now if you look at lean mass, there was initial reduction, but then it was maintained. So the lean mass was maintained, and they also looked at the muscle function by looking at the hand grip. And there was an improvement in the strengthening of the muscle function in these patients with obesity. So this tells us that looking at the body composition is another additional measure that we should be utilizing in our patients apart from just the weight. Step Up is another program where they looked at semaglutide 7.2 milligrams. And I'm just going to present the post hoc analysis again on these two parameters that I've been discussing. So they looked at, this is a post hoc analysis where they took the subpopulation and did MRI DEXA scan on these 55 patients. And what it showed was that 85% of the weight loss came from the adipose tissue, and there was preservation of the lean mass, and there was reduction even from the fat tissue within the muscle. There was 31% reduction in the visceral adipose tissue volume as well. So improvement in the body composition with maintenance of your lean mass, that is important because that's the biggest metabolic organ as already shown by my colleagues. What about OASIS 4 trial, which is on oral semaglutide 25 milligrams? And again, I'm just going to focus on these cardiometabolic outcomes. So just to explain it to you, the different bars, if you look at all the 3 bars, which are blue in color, all the participants is the light blue color, which is on oral semaglutide. Then the next one is at week 64. And this bar actually includes patients who again achieved the BMI and the waist height ratio treatment. And then now we are dividing it into different cardiometabolic parameters, including how many of those achieved normoglycemia, improvement in HDL, target blood pressure, as well as improvement in triglycerides. So if you look at it, 100% of the patients who achieve both the BMI and the waist height ratio, they managed to achieve normoglycemia as well as improvement in the triglycerides and the target blood pressure in 61% of those patients. Again, combining all these cardiometabolic outcomes, it shows, so these are the proportion of the participants again who actually achieve both the BMI and the waist height ratio targets, and 100% of them achieved more than 2%, more than 2 low risk cardiometabolic outcomes. So now I have given you 2 additional markers, which is your BMI less than 27, although we do need more research into it, and the waist height ratio. So how do we choose out of all these anti-obesity medications in our patients who have obesity and type 2 diabetes? So the first step is assessing the clinical history. And in your mind, always think about what is the contraindication here. Are there any cautions from the history that I need to look into? What are the other comorbidities? And then based on the guidelines, thinking of, does this patient have obstructive sleep apnea, or this patient has MAFLD or MASH or with fibrosis? And that's how you will start putting these patients into what medications they require. Always listen to your patient. They will always give you cues. They will tell you whether they feel hungry, whether their appetite is back, they do stress eating, they get cravings, but listen to those because that help us in deciding what is the right medication for the patient in front of us. Consider combination therapy, but along with the lifestyle intervention, which, as my colleagues have mentioned, is the foundation. Medications alone, they won't help you unless and until the lifestyle intervention is there. And then we have to consider the cost and the coverage as well. So I really like this work done by Deborah Horn, and that was published in 22, giving us a 5C model, how to choose an anti-obesity medication. And then what was done by the clinical practice guideline in Canada, and these are the guidelines from 2020 by the Canadians. And this is the 5A approach. First, asking the permission from the patient whether they are ready to discuss the weight, assess the individual, look at the clinical history, look at what their ethnicity is, how is the fat distributed, and what are the complications, and then using the Edmonton obesity staging criteria. Then advise on obesity therapy. First step is again lifestyle intervention. Especially with these incretin-based medications, you want to preserve the muscle mass. And I've already shown you in different studies, especially like Step Up trial and the Semaline trial, that it is important that we tell the patients in all these incretin-based therapies, nutrition and doing strength training at least twice a week. And then considering what is the BMI, what other comorbidities that patient have, and then what will be the right pharmacotherapy for the patient. and for the right
Rahila,
patients,
2 minutes.
okay, thank you, bariatric surgery. Then agree on the goals and assist with any barriers. Now, putting it all together in clinical practice. So this is the first case of a 52 years old female, Asian in origin, 35 BMI with central obesity, type 2 diabetes for 7 years, already on combination of metformin and empagliflozin. But she has developed MAFLD with F2 fibrosis. She is EOS stage 3. Advise and agree on a plan, but treat the obesity as the underlying cause of the comorbidities. And then when you're assessing the treatment response, it's not only about weight, not only about HbA1c, it's about improvement in the glycemic control, looking at TIR, looking at the waist circumference and the waist height ratio, improvements in blood pressure and lipid profile, and also in her case, any improvement in FibroScan. And then using EOS staging for following up on how she is progressing. And this is the last case I'm presenting, 29 years old, local in origin, 44 BMI, but look at the comorbidities. Again, EOS stage 2. Important thing is, yes, we are planning for bariatric surgery, but to reach that, starting him on a tirzepatide along with lifestyle intervention, and then looking at the assessment response. So my take-home message is, a more complex definition of clinical meaningful weight loss, which is individualized with evidence-based approaches to treat obesity and associated complications, and moving beyond weight, because we need to incorporate the waist measurement, waist height ratio, and the organ-specific metrics into the treatment evaluation, and then using the obesity medications wisely along with the lifestyle intervention and communicating using the 5A approach. Thank you so much for listening.
Thank you, Dr. Rahila, for another great talk this evening. We now move to our next speaker, Dr. Sarah Suleiman, and she's going to present to us obesity management snaps from guidelines. Dr. Sarah is a consultant endocrinologist, diabetologist, and bariatric physician. She is the clinical lead for obesity and metabolic surgery, also the clinical lead for the genetics of diabetes and endocrinology at Imperial College London Diabetes Center, Abu Dhabi. She is the chairperson of the MENA Working Group World Obesity Federation. Dr. Sarah, please join us, share your slides, and start your presentation.
Good evening. I'm sorry, here we go. Thank you very much for the kind introduction. I've got a huge topic, but I'll try and make it as simple as possible. Obesity management snapped from the guidelines. Thank you, Rahila, for making my life a lot easier. So we have a huge challenge. 1 in 7 people in the world live with obesity. And if we follow guidelines, we would be treating everyone with a body mass index of over 30 or a body mass index of over 27 and 2 complications, type 2 diabetes being one of them, so we already have one. We know that about 70 or 80% of our patients also have hypertension, dyslipidemia, or other complications, which automatically makes the diabetic patient warrant obesity management.
Dr. Sarah, okay, let's see your slides, maybe.
Oh, I'm sorry.
Your slides.
I'm sorry. I thought I had shared them. Let me try again. Can you see my slides now?
Start coming. Yes.
Okay. So if we follow guidelines, these are the old NIH guidelines from 1998. We would treat everyone with a BMI of over 30 or over 27 with 2 complications. It used to say, having failed lifestyle interventions, thankfully, since 1998, that has been crossed out. There are many, many guidelines for the management of obesity, some of which are just weight-related, some are specific to pharmacotherapy, some are specific to complications. I'm not going to go through all of them. I will try and include our local guidelines, so the national guidelines led by the Ministry of Health and the Department of Health Abu Dhabi standards of care for obesity management as we go along, but I'll focus on the big 3. There are also local guidelines for the whole region, the GCC, which were developed in 2020 under the guidance of the World Obesity Federation. They're free to download. I would highly, highly recommend you download them because they give guidance on who goes to primary care, who goes to secondary care, who goes to tertiary care, and what support that system needs. So our aim today is to look at the different guidelines, try and compare them, identify who should receive what therapy, recognize when obesity becomes the primary treatment target, and try and address the barriers to treatment. The underlying narrative is that every guideline now agrees that obesity is a chronic disease. The disagreements tend to be on who qualifies, when to escalate, when to stop, and we'll speak about them. So obesity is a chronic, relapsing, progressive, biologically driven, treatable disease. Therefore, its treatment has to be effective, safe, and lifelong. We spoke about the numbers previously. The one I want you to look at is the right corner. There's a 5 times increased risk of type 2 diabetes. So an individual with type 2 diabetes does have obesity unless proven otherwise. That's the default, apart from type 1, of course. But obesity isn't about appearance. It's associated with over 220 health risks, including the metabolic ones we often see, mechanical, sleep apnea, knee arthritis and others, cancers, polycystic ovarian syndrome, and physical functioning, as well as the mind. It's not all doom and gloom. We know that weight loss, even a small amount of weight loss, improves glycemia and blood pressure. And as Dr. Rahila has told us, the higher the weight loss, the better the benefit, 15% being the target we speak about for type 2 diabetes remission, reduced cardiovascular mortality, and heart failure improvement. It is a huge burden worldwide, and particularly in our region. The numbers are staggering. My colleague who spoke earlier, Dr. Lamine, has recently published that over 2/3 or almost 2/3 of individuals in the UAE who presented to the Dubai healthcare system suffer with overweight and obesity, with about 1/3 of individuals having obesity. And similarly for diabetes, we're running at about a 17% risk. So I think the figures vary depending on where you look, but they are huge, and that is the problem. Does it really matter? Well, yes, if about 1/3 of people have it, and the mean delay between a person recognizing they have obesity and presenting to lose weight is 7 years, then we have a problem, particularly as in a local study, the Action-IO, 70% of physicians felt that the patients were not interested in losing weight. What that means in our diabetes clinic is that it is a huge problem. People don't get treatment, and it's not because treatment's not available, because it is available for people with diabetes. It's because the conversation doesn't start. If you or I see a patient with a BMI of 34 and an HbA1c of 6%, we see them in 3 months. That conversation doesn't start. So what's the current landscape? We spoke about many guidelines, some of which focus on definition and diagnosis, some of which are diabetes specific. The ADA in particular not only produces standards of care of diabetes, but recently has produced standards of care for obesity, some for what medication for which patient, some for surgery, some for organ-specific disorders, such as the European Society of Cardiology and the gastroenterology guidelines for MASLD and MASH, and our regional ones we briefly mentioned. It's evolved over the last 20, 30 years, starting from ones that were mainly lifestyle driven to earlier last year, the Lancet Commission, which reframed obesity as a disease, and we'll speak about it in a minute, and more recently to the EASO and the ADA guidelines, which focus on how to treat that individual person or personalization of care. Unfortunately for us, history matters because many of the local policies are referring to the 1998 NIH guidelines, which not only are BMI based, but also put in this 6-month failure of lifestyle treatment. A bit of a problem. So what 5 things have changed in the last year? Obesity is now diagnosed, not just measured, and that is mainly due to the Lancet and the ASO guidelines. Waist-to-height ratio has entered the mainstream, and I'll speak about that in detail in a minute. Particularly NICE uses that, and the EASO guidelines. Drug choice has become complication-led. So, for example, if cardiovascular disease is the issue, semaglutide would be an option, whereas if fatty liver disease, tirzepatide might be a better option. Oral incretins have arrived, and therefore increasing access and hopefully reducing the running out of medication. And guidelines now actually plan for lifelong continuation and not stopping as the previous NICE guidelines were. Where there are differences, so there are many things that they agree on, and there are things that guidelines disagree on. So diagnosis has moved beyond BMI, and that's by the Lancet, that says that BMI plus one measure, or actually you don't need BMI at all. If you have 2 measures of adiposity, you get obesity. And then depending on an 18-organ system diagnostic criteria, you either have clinical obesity or preclinical obesity. By definition, a person with diabetes, although they don't say that, they say a combination of hyperglycemia, triglycerides, and a waist circumference makes you clinical obesity. Effectively, for us, all our patients in a diabetic clinic have clinical obesity. EASO and previously the American Obesity Association use the ABCD method, so the adiposity-based chronic disease. And what they say is that BMI of over 30 or even over 25 with a waist-height ratio of over 0.5, you should then assess the staging or look for complications. NICE in the UK is based on cost effectiveness, and therefore they tend to go for a higher BMI for treatment. However, they also recognize that waist-height ratio is very important. The ADA guidelines are very clear and suggest treatment at much lower BMIs, and all of them suggest that ethnicity ought to be looked at. What does that mean? It means that if a patient in front of me has no organ dysfunction and BMI of 33, they're at a much lower risk than someone who, for example, has heart failure or fatty liver disease with a BMI of 28, and I'll show you a picture in a minute. But it also means that what we need to look out for are simple things. So a tape measure can be found everywhere. So historically, we used to use BMI or the WHO classification, but it does not differentiate between fat and muscle, where the fat is, or gender or ethnicity. But this is just an example. If you look at the gentleman on the left, he has a BMI of 32, but he's all muscle, and therefore his waist circumference is low, his blood pressure is normal, his HbA1c is normal, whereas the gentleman on the right has a BMI of 28, so not obesity by WHO guidelines. However, he has a body fat percentage of 32%. He has a waist circumference of 103, high blood pressure, he's pre-diabetic, and has a high cardiovascular risk. So he would be clinical obesity based on both the EASO and the Lancet Commission guidelines. Oh, sorry. So what do we need? We need BMI, yes, because that is a population level risk screen. We need a waist circumference, waist to height ratio, waist to hip ratio, which tells us about fat distribution, and a higher hip circumference actually reduces the cardiovascular risk. And in very few individuals, we will need more detailed measures such as bioimpedance or DEXA. Try and reserve them for those who are genuinely ambiguous. So waist circumference tells us where the fat is. Is it visceral? Is it central, subcutaneous? It predicts type 2 diabetes and cardiovascular disease. And further information, and again, there are these ethnic differences. So for example, for a Caucasian man, a waist circumference of less than 102 is acceptable, whereas for an Arab man, that waist circumference needs to be below 90, quite a big difference. Waist to height ratio is a new kid on the block, and actually it is fantastic because you can use it in any age, and it is comparing the person to themselves. So a ratio of below 0.5 confers normal risk, 0.5 to 0.6 is high risk, and more than 0.6 is very high risk. It's very easy to remember, and I would urge you to do this for all your patients. We're certainly trying to introduce it into our EMR. Ethnicity-specific thresholds, that's the most under-applied recommendation in this region. We know that NICE, ADA, ASMBS, and EASO all say that individuals of Asian, Middle Eastern, Black or Afro-Caribbean should all have a body mass index adjustment of about minus 2.5. So the equivalent BMI would, for a BMI of 30 in a Caucasian, would be 27.5. Unfortunately, we do not have local data, and therefore, in the absence of local data, we're using Caucasian data, which underestimates the risks. If we think about the Lancet Commission, we spoke briefly about the preclinical obesity and the clinical obesity. Preclinical obesity is where there is excess adiposity, but there are no signs or symptoms of organ dysfunction with that. And therefore, we ought to focus on prevention, but not let these people loose, so that we prevent and avoid treating late. Clinical obesity is in individuals who do have end organ damage, and they require management straight away. And to confirm excess adiposity, it would be BMI +1, waist circumference, waist height ratio, waist hip ratio. And once you've diagnosed it, you then look at end organ damage. And it means that when you apply for insurance, you can say that this is clinical obesity with hepatic involvement or sleep apnea, which has a far higher weight than a BMI of 34 alone. The diagnostic criteria for the Lancet Commission include assessment of the cardiovascular, so HFpEF, HFrEF, atrial fibrillation, DVTs, sleep apnea, metabolic, so hyperglycemia, triglycerides, and low HDL, liver dysfunction, renal dysfunction, and everything you can see there. The EASO framework, on the other hand, is very similar, but here it suggests that we have 5 stages that we need to go through. So diagnosis, anyone with a BMI of over 25 and a waist height ratio of over 0.5. Measure the waist circumference in everyone, ethnicity specific, medical complications, functional impairment, mental health behavior. And the next stage is staging, looking at severity, and then agree personalized treatments with the patient and intensify therapy. So personalized treatment could include lifestyle, medication, target weight, and then intensification may be, for example, surgery. And the difference from a BMI-driven care is that 2 patients with a BMI of 32, one can be at step 1 with no clinical component, and the other at step 5, having already failed a trial of medication. The Edmonton staging system was the first one out of the block and started in 1998 and reported in 2000 initially. And what they say is the stages of obesity go from 0 to 4. Where 0, there are no complications. So for example, for glycemia, that would be normoglycemia. Stage 1 would be IFG or IGT, so pre-disease. Stage 2 would be diabetes. Stage 3 would be diabetes with retinopathy, for example. And stage 4 would be end stage, so diabetes with blindness. And what they've shown is that this predicts mortality better than BMI alone, even if the BMI is hugely discrepant. And the GCC and Lebanon guidelines have actually recommended that we follow the Edmonton obesity staging system. What that says is for people with stage 0 and stage 1, they can be seen in primary care. Sorry, that arrow seems to have disappeared. Whereas stage 2 and above ought to be treated in secondary or tertiary care. What do the guidelines agree on? That obesity is a chronic relapsing disease, that weight management per se is a treatment goal for individuals living with type 2 diabetes, that the health outcomes outrank the number on the scale. So for example, for cardiovascular disease, even before the weight loss appears, there is a mortality benefit. Treatment is stepped and combined, not sequential and exclusive. It's not medicine versus surgery. It's actually what that patient needs. And sometimes it's medicine and surgery. Incretin-based therapy is now first-line pharmacotherapy, and stigma is a problem. Where do they agree? Is BMI a diagnosis or a screen? And I think most people agree now that it's just a screening test. However, there is still NICE and the ADA, ADA diabetes, not obesity, still are keen on BMI. Where does specialist care begin? So NICE, for example, restricts semaglutide to specialist overweight and obesity management services, although interestingly, tirzepatide can be initiated in primary care. Everyone else says everyone can be treated. In Abu Dhabi, obesity-trained physicians can prescribe, both in primary and secondary care, can prescribe obesity management medications. This is a health system decision, dressed as a clinical one, but guidelines do differ. To continue or to stop obesity medications, so NICE used to say stopping at 3 or 6 months if there is no significant weight loss, and stopping at 2 years if there is significant weight loss. Thankfully, that is changing, and most guidelines now recognize obesity is a lifelong disease and needs lifelong therapy. When do we refer for metabolic bariatric surgery? If you are in the UK, you refer very late, BMI of over 40 or over 35 with complications, and that's simply due to capacity. Whereas the ASMBS and IFSO, both international bariatric surgery guidelines, show that a BMI of over 35 would qualify and over 30 with complications would. So because there are different guidelines, it doesn't mean we should do nothing. It just means we need to understand which guideline we're going to follow and do it properly. I'm going to move away from that. So who gets what? Lifestyle, pharmacotherapy, bariatric surgery. Now, how do we decide? I'm going to start at the very beginning. So we need to understand the difference between prevention and treatment. And prevention can be lifestyle alone, but treatment often is everything else. And prevention is key to managing the current epidemic. But once obesity is established, treatment is required. And having medication or surgery should not be stigmatized. It's not an easy way or cheating. I'll give you an example. When a person smokes, we ask them to stop to prevent lung cancer. Once they develop lung cancer, we treat the lung cancer. We do not ask them to stop smoking. And similarly, people who have obesity should be offered therapy. So lifestyle alone, who needs it and for how long? It's reasonable for people with stage 0 or 1 with no established adiposity-related complication, or those with overweight with no complications. People with recent onset impaired fasting glycemia, again, might be sensible. What does it actually mean, though? Quite a lot. So it's in high-frequency counselling, 16 sessions in 6 months, targeting a 500 to 750 calorie deficit, monthly contact afterwards, and protecting lean mass. Anything less intensive than that has no benefit at all. So if we use the look ahead and go for really intensive lifestyle, we're looking at 8 to 9% weight loss. And it doesn't matter how much you bully that person, they're not going to get any further than that. And that we know. And we should know that if a person has not achieved weight loss, we should move on to the next stage. So lifestyle, intensive lifestyle, 12 weeks, and then we move on to medication or surgery. So what do the guidelines say about food? And the ADA are best at this. They've given some very clear guidance. It needs to be delivered by a nutritionist or a dietitian who has experience in diabetes and obesity. It needs to be structured either as low calorie or very low calorie if we're aiming for remission, looking at as natural food as possible, so looking at vegetables, whole fruit, legumes, lean meat, and trying to avoid ultra-processed foods and sugar-sweetened beverages. A Mediterranean-style diet reduces cardiovascular disease. And I won't go into the details, but that guideline is the strongest for that. What about physical activity and protecting lean mass? Again, the new ADA guidance is excellent, and it looks at 150 minutes of moderate to rigorous aerobic exercise, alternate days. And those who do HIIT training can do 75 minutes per week because they just have that higher intensity. Aim for resistance training, not just the walking. In the UAE, outdoor activity is difficult, so trying to get things on YouTube or inside a mall or going to a gym, trying to address gender bias is important, and set activity times. If you are prescribing obesity medications, you should be prescribing resistance training and adequate protein to be following any of the guidelines. What about behavioral health? There are lots of guidances on cognitive behavioral approach, on screening, and there are different screening tools, sleep, serious mental illness, and antipsychotic medications. Weight recurrence is a behavioral event as well as a biological one, so understanding what happened and trying to treat it. And it needs to be delivered by an expert. We are not experts as endocrinologists. but not everyone can see a psychologist. And what we need to do is to be able to identify who needs to be referred. What about pharmacotherapy?
2 minutes.
Okay, so I will go. There are now 10 medications which are licensed, all of which are unsafe in pregnancy. There are frameworks which help us decide who to give what to. So this is the EASO guideline, which is excellent. It tells us about obesity alone or with complications, what to choose for which. And safety concerns, really most of the safety concerns are not a huge issue. GI side effects we need to look out for and to titrate the dose slowly. It's a marathon, not a sprint, and I think it's important for us to understand that to support our patients. I'm actually happy to stop there. So we need to have some practical guidance to the patients before the first dose. We need to tell them that this is a lifelong treatment, that we are treating complications as well as obesity alone, that tolerability is something we can play with. We can reduce the dose, we can half it, we can slow it every 10 days, every 2 weeks. But we need to tell them that we're in it together as a long-term journey. Thank you.
Thank you very much, Dr. Sarah, for excellent talk. Now, I'd like to invite all speakers to join us. Open the camera, open the mic. And I'd like to ask the participant, we have more than 120 participants in this course. I'd like them to ask questions. We already have several questions. I'm going to address them. Perhaps I'd like to start with Dr. Fawzi, and there's a question to you. Is insulin resistance the root cause for all PMOS/PCOS cases?
Such an interesting question, and I can answer it for 30 minutes without a break. But
No,
briefly, no.
shorter answer.
Briefly, no, it's not the root cause in all the cases. PMOS is actually one of the syndromes that are associated with insulin resistance. In one of the slides, I mentioned a list of syndromes. So PMOS is part of that. And 2/3 of the cases are actually having functional ovarian hyperandrogenism. We can say in many studies, it showed that patients who have PMOS, they have, you can say, a higher level of insulin resistance compared to the counterpart with the same BMI. So yes, they have high prevalence of insulin resistance, but insulin resistance per se is not the root cause. It is associated with PMS.
Thank you, Dr. Fawzi. Another question to Dr. Al-Amin, and this directly addresses the muscle. People with who are lean, who are not obese with muscle, how to detect them, how to manage them.
Okay, this may need more than the 30 minutes of Fawzia there. This is a very tricky question. Lean muscle D is a very tricky diagnosis, just like the lean PCOS in the older days. Probably the geographical area where there is the highest prevalence of lean muscle D is in the Far East Asia, and for some reason, the second highest prevalence in the Middle East and specifically in the GCC countries. So this tells that it may be related to some ethnic pathophysiology or genetic predisposition that needs to be addressed in higher level or population-based studies. Lean muscle D is by definition someone who is either overweight or normal weight with an evidence of muscle D. Usually goes under the radar because usually the entry point will be the BMI. And Dr. Asad have very elegantly alluded that to obesity. BMI is just a number that may take you towards clinical obesity, but sometimes even overweight, people living with overweight may have obesity-related or metabolic-related disorders. So even with normal BMI, overweight, the risk of muscle D is there. It's yes, between 15 to 30% of the total muscle D. The treatment is even trickier because only resmetirom might tackle the problem from the roots, but the GLP-1 receptor agonist might not be the best option. Pioglitazone have been tried in many small studies with reasonable outcome. However, still lifestyle intervention might play a role. The aim here is to increase the muscle content and not to lose fat, because they have very little fat located in the wrong places, and they are dysfunctional. So the aim here is completely different from the routine muscle D.
Thank you, Dr. Alameen. Clear. A question to Dr. Rahila, and this is perhaps you could give your approach regarding a case of elderly patient with BMI 35 to 40, uncontrolled diabetes, unable to do physical activity, developed side effects, severe side effect from low dose semaglutide or tirzepatide. How would you approach this case?
This is what we see almost every day in our clinics. First thing is always talking to the patient that why they are unable to do physical activity. There is always a reason behind it. And I think majority of the patients, they actually take it that we are asking them to go to the gym. And it's not about going to the gym. It's about what you can do in your daily physical activity. And or if you have simple exercises which you can do at home. I always tell them they can use resistant bands, Pilates at home or yoga, or put on a YouTube video which helps them even in elderly if somebody puts it on and does it with them, or working with the physiotherapist. So it's building up slowly, starting from the basic. But that is the major myth or misconception that I see whenever you talk about strength training or whenever you talk about exercise. Everybody says, I cannot do it. Also assess in the history and examination what is the reason for not doing it. Is there any osteoarthritis? Is there any back pain? What are the other reasons? Once you address them, then at least patients can go back to the exercise. Secondly, regarding side effects on low dose of treatment, I always tell them, first of all, looking at what the side effects are like nausea, vomiting, constipation, or diarrhea, making sure they're drinking plenty of fluids. Even in this summer weather, people will come in and they will say, I've got nausea, can you give me anti-sickness medication for it? That is not the answer to treat the sickness and just give them the ondansetron or anything that is being available over the counter here. It's about making sure that the patient is drinking enough fluid. That's the most common reason for that. Second common reason I find is constipation. They don't have enough fiber in their diet. So you have to address all these, and then yes, you can restart the treatment on low dose and let the body get used to the medication. There's no point in escalating every 4 weeks. Even in type 2 diabetes patients, if you keep them on the low dose, they are getting benefit from it. And then looking at the combination therapy, looking at what are the medications that need to be combined. That's how I will approach such a case.
Thank you, Dr. Rahila. Moving to Dr. Sarah, perhaps along the same line as well. Now, a patient with chronic renal failure, morbid obesity, who needs to lose weight to do surgery for prosthesis. What would be your approach?
I'm going to tag on to Rahila. I agree with her. The first thing to say is there is a misconception that chronic renal disease disqualifies a person from getting GLP-1s. It absolutely doesn't. It is an indication. And interestingly, the indication is for an eGFR between 20 and 60. So people who already have established renal disease. The other thing that was not mentioned so far is metabolic bariatric surgery. So metabolic bariatric surgery reduces death from renal failure by 80%. So actually, if this person is going to become fit for surgery, the quickest route to that is metabolic bariatric surgery. And I would probably even offer it to Rahila's person with a BMI of 35 and poorly controlled diabetes. I agree with her that the more we learn about GLP-1s, the more we are happier to titrate it. So I have patients who start with 10 clicks over 2.5, tiny dose, and then they can tolerate it. And if that's what it needs, that's what it needs. If it takes 6 months, it takes 6 months. It's not an issue. It's a marathon, not a 100-meter race.
Thank you, Dr. Sarah. Back to you, Dr. Fawzia, and question related to insulin resistance. Say you mentioned about the assays not validated. And here perhaps a comment and question. Then why a lot of physicians, they are ordering insulin levels, they're checking HOMA and other things. How would you approach perhaps
So,
patients and physicians who are doing this?
yeah, so Dr. Khalid, the answer to this is the same, that in routine
30
clinical,
minutes or what?
no, it will be brief.
Okay.
Routine clinical practice, there is
Yeah.
no rule of doing any of those tests unless you are suspecting genetic cause of insulin resistance. Yes, research setup, you want to prove something, you go ahead and you do any gold standard or surrogate clinical marker. Again, it comes to the same point that we are treating the patient. We're not treating the pathophysiological state of insulin resistance. So those who are practicing it, I think it should not encouraged so much by the healthcare professionals, and we probably do more education to the patients in our own capacity that we are not getting any yield out of it because of multiple reasons. You're not aiming for a treatment for that. As a lab value, assays are not validated. Cutoff is quite variable in the different practices. Under the research setting, under the study setup, yes, we can do that. But for routine clinical practice, to make patient that you are insulin resistant is of no value. So we should discourage that.
Thank you. Very clear message, I guess, here. Thank you, Dr. Fawzia. Dr. Lameen, back to you, and I need your help with this question. I would just take the last part, which is more clear. How does sarcopenic obesity impact insulin resistance?
Okay, thank you very
Easy
much.
question.
Very interesting question. And it's a very hot topic these days. So Dr. Sarah also mentioned that the central obesity sometimes might play the major role in metabolic and cardiovascular outcomes. So not all patients with obesity are having high BMI. Not all of them are having the uniform distribution of adipocytes or fat cells. Sarcopenic obesity, in fact, people with obesity are having more muscle mass than the counterparts. There is the misconception that with obesity, there is sarcopenia in everyone. In fact, before intervention, the muscle bulk of any person living with obesity is higher than the counterpart, same age and gender, with no obesity. This is a fact and has to be clarified beforehand. Sarcopenic obesity starts either after intervention, for example, starting with any strenuous weight reduction method. There's an aggressive lifestyle intervention, pharmacological therapy, even surgical intervention. The massive reduction of fat is associated with also massive reduction of muscle mass. If we started having the zigzag where we lose fat and muscles and then we regain weight, we regain 70 to 75% fat and the remaining will be muscles. Then when we lose again, we will lose around 40% muscle mass and 60% fat. When we will regain the 75%. So with this zigzag diet and undiet, we'll accumulate more fats and lose more muscles. And this what makes, and this is very important, the question comes from the patients, the first intervention was remarkable and the second and third were less effective. And this is the core reason for that, because you are regaining fat and working on this fat will be much more difficult than working on the 40% muscle that you had earlier. So the sarcopenic obesity is a hot topic, and also it's more apparent with advanced age, where we do get sarcopenia by physiology. And when we gain fat and lose muscles, there is again sarcopenic obesity, and there are some genetic predisposition for that. The treatment for it has to be more careful. The risk of complications might be higher. Cardiovascular, musculoskeletal complications might also be higher. And even with the advanced age, the risk of fall is way higher than the people with non-sarcopenic obesity. So it needs to be tackled with care, handled with care, and the specialized, hopefully specialized care as much as possible.
Thank you, Dr. Lameen. We'll move to Dr. Rahila. Short question, because I'd like to cover as much as of the questions asked here. So question to you about intermittent fasting. What's the evidence related to weight loss here?
Okay, so intermittent fasting, yes, there was some evidence, but not for every patient. That's the first thing. And then intermittent fasting is what patients are doing in those hours when they are not fasting. So people take this concept that I'm doing intermittent fasting 16 hours, and then the rest of the 8 hours they're having all the calories. So it has to be done properly under the dietitian. So dietitian has to look at what number of calories and what is the plate made of, what is the amount of carbohydrates, fat, and protein in there. So it has within their culture, and that is why I always say they have to be done by a person who is trained in it.
There is some voice interruption, Dr. Rahila. Thank you very much. We got most of that answer that you elaborated on. Dr. Sarah, question about, I think this is very much related to a work that you have done with the Department of Health. So the question here, can internal medicine specialists order obesity medications like GLP-1, and will it be covered by insurance?
So if you're looking at after a patient who is Emirati and has TIQA 1 or 2, and you are within the DOH jurisdiction, so in Abu Dhabi, yes, so long as you have some obesity training, and that could have been upskilling by the Department of Health. There's over 800 physicians who've upskilled, or scope certification, which can be done at home over a weekend. I would highly, highly recommend it. Every time I go in, I learn a bit more. And it just means, like anything else in life, if you have experience in treating obesity, then you have a license to treat obesity. It is a bit unfair that obesity is not treated like other chronic diseases. And the thought process is that anyone, including the gym instructor, your local pharmacist, everyone else can prescribe a GLP-1. So I think the Department of Health are trying to get a handle on that. And I think the way they've done it has been excellent.
Thank you, Dr. Asar. This is the perspective from Abu Dhabi. Can we hear different perspective from Dubai about who can order? Is it covered, not covered?
I am happy to answer that.
Okay.
I'm happy. So in Dubai, it's quite mixed at the moment. Actually, it is available over the counter, even without prescription, which is not the right way of doing it. It's not about weight loss, like we are saying, it's about obesity management, as it's a chronic disease and like a chronic disease. Regarding coverage of insurance for obesity and its comorbidities, it's not covered in the private practice at all by any of the insurances at the moment. And it's about making patients understand that why it should be a prescription drug, why they should be looked after by a physician who is trained in obesity. And it can be a GP, it can be internal medicine. Like Sarah said, that they should just be upskilled or they should be trained in obesity, and any of them then can prescribe it and do the obesity management properly as a chronic disease.
Thank you, Dr. Rahila. Perhaps back to you, Dr. Asar, a question about how much daily protein to support and avoid the muscle loss with GLP-1 treatment.
So thank you very much, Dr. Amin, for a very eloquent description of sarcopenic obesity. And to try and avoid sarcopenic obesity, my son is my best reference, but basically it's 1 to 2 grams of, he's a stick insect. He does not have obesity at all, but he's going to the gym to try and bulk up. And he's correct. It's 1 to 2 grams of protein per kilogram body weight. And what that means is that plus resistance exercise, you will build muscle. Now, we are a group of endocrinologists, and I've answered this question many times incorrectly. What bit of your body results in insulin resistance?
Skeletal muscles.
It is not adipose tissue.
Skeletal muscles.
It is skeletal muscle, exactly. So skeletal muscle is the one that uses insulin efficiently. If you have enough skeletal muscle, then you will not get insulin resistance. And if you don't have enough skeletal muscle, you will get insulin resistance. And that's exactly why we tell people to do resistance training, to have sufficient protein. Now, having 1 gram per kilogram body weight is an awful lot. So for an individual with obesity, 100 grams, for example, 100 kilograms needs 100 grams. A chicken breast is 30 grams. A salmon or a steak is 30 grams. An egg is 5 grams. So if they were just to eat eggs, they would need to eat 25 eggs in a day to achieve the amount of protein they need, which is why there are cheats. So Greek yogurt, there are many cheats. You need a good dietitian. They're worth their weight in gold. But if you're able to achieve over 100 or over 1 gram per kilogram body weight, you are very unlikely to develop sarcopenic obesity, and obviously with the resistance exercise.
Thank you, Dr. Sarah. Now, a question to all of the speakers. I'd like you to pick one take-home message for your healthcare provider, whether this is a GP or internist that you'd like to enhance or highlight from your talk. Just one take-home message. And we'll start with Fawzia, and then we'll end later on with Fawzia with another question. So Fawzia, one take-home message, please.
See your patient holistically. Just don't listen to them and don't judge them for being obese. There are certain elements which push them towards eating habits are not good. They cannot move around, and don't jump to medication immediately. There are a lot of other things we can help. As I mentioned in the key home message, that see holistically and design their lifestyle intervention. Even if they're wheelchair bound, they can do some physical activity to enhance the sensitivity to the insulin.
Thank you. This is one page. I just want one message.
Yeah.
Thank you. Dr. Lamine, one take-home message.
Probably it's out of the context of my presentation, but obesity is a chronic disease that needs a lifelong intervention. This has to be well taken care of by the healthcare provider and the patient himself.
Thank you very much. Dr. Rahila.
So my one take-home message is it's beyond weight, and it's chronic long-term management because it's a chronic relapsing disease.
Very nice. Dr. Sarah.
Give your nurses a tape measure and don't see any patient who has not had a waist-height ratio.
Waist-height ratio. Thank you. Now, the same take-home messages to the patients, starting in reverse. Dr. Sarah.
It's not your fault. Obesity is a disease. Get treatment. You're not taking the easy way. People have treatment for diabetes, high blood pressure. Why is Mounjaro stigmatized? Get the treatment. It's not your fault.
Thank you very much. Rahila.
Explaining to the patient the symptoms that they are having of obesity, it's because of the chronic disease and why they are having them, so that they can understand why we are actually prescribing the treatments to them.
Great. Dr. Lamine.
Okay, you've been living with this obesity for decades, so don't look for fast results. So bear with us and take it step by step.
Thank you. Very nice. Dr. Fawzia, we'll end with you.
Remove all the instant food delivery application from your mobile.
Okay, we'll end on that note. Thank you very much.
Just
And then ask
one.
the team of EDS to show me the last 2 slides so that we tell our audience about our next module. So thank you very much for joining us. Very engaging. I learned a lot. Thanks for all the speakers. Thanks for the audience. And continue with the Summer School of Diabetes. Our next module will be in August 4th, where we'll be discussing type 2 diabetes management, oral therapies. Please join us. Please see our previous modules on EDS YouTube channel. Any more announcement, Sharon and the rest of the team? I guess that's the end of our session today. Thanks to all of our speakers, to our audience, and enjoy the rest of the night. Thank you very much.
Thank you, Dr.
Thank
Khalid.
you.
Thank you,
Bye.
all the co-speakers. Have a lovely night.
Thank you.